So Dr. Fuller had a great suggestion. We'll take a vote before and after, and just kind of see how our moderators, our panelists are effective in changing your mind. 36-year-old male, fall playing tackle football on the weekend with his buddies. Isolated injury, no medical problems. Right-hand dominant, works as an accountant. So let's have the ARS clavicle, operative or non-operative. Again, 35-year-old male, weekend athlete. Accountant. Non-dominant side, I think it was. 50-50. All right. So let's see what we got. All right. So it looks like we have Dr. Kazanjian coming first.
That's it. That's it.
Oh, that's
it.
Okay.
I used your
that's
slide.
That's it. All right. Sorry.
Because that's what the lecture's about, using this slide. Thank you, Dr. Rehman. Thank you once again to the co-chairman for allowing me to participate, and for Temple University. It's been like the 4th or 5th year I've been part of this program, and it continues to grow. Actually, I'd like to thank Dr. Fuller. He was initially doing operative, and I had non-operative, and he switched his stance and allowed me to win this debate. So I'd like to thank him very much for switching. So why fix this fracture? 36-year-old, weekend warrior, plays football. He's an accountant. It is his non-dominant arm. One, he's young. It's tax season. He's very busy. It is a middle third Z fracture. This is the fracture at risk, and looking at all the literature where we talked about fixing fractures of the clavicle versus not. The literature is going to bear it out, old and new, and I'm going to prove it. So when I started training, which wasn't that long ago, I did my residency from 99 to 2003, even back then, our attendings would say, oh, you have a clavicle fracture, you put one piece of the clavicle on this end of the room, put one piece of the clavicle on that end of the room, they're going to heal, they're going to do fine. Well, in literature back in 97 to 2006, it proved that non-operative treatment of clavicle fractures gave poor results, had sequelae, and had deficits that were not seen traditionally in review of clavicle fractures, which started a revolution in evaluating clavicle fracture treatment, whether it be non-operative versus operative. So why do we operate? In a landmark study by Robinson and Court Brown in JBJS, they studied 868 clavicles. An overall non-union rate was 4.5%, but what they delineated was a specific fracture, the middle third Z-type fracture, the Z fracture pattern with butterfly fragments that had an incidence of 21% non-union. So they postulated that the potential of fixing this type of fracture would, one, decrease the risk of non-union and malunion, which were symptomatic and problematic for patients who sustained middle third clavicle fractures. So the study that started it all, the study that started the snowball effect of starting fixing all clavicles and industry getting involved in clavicle fracture fixation, was the study out of JBJS, the Canadian study, which evaluated non-surgical treatment of middle third clavicle fractures versus plate fixation, superior plate fixation of middle third clavicle fractures. What they found all across the board was that non-union rate was substantially lower. Symptomatic malunions were 0 to 9. Operative patients were more satisfied with function and cosmesis. Healing was substantially better and a lot earlier. And surgery all across the board, early and late, had better constant and dash scores in patients that were fixed with superior plating techniques. So if you want to look at Cochrane reviews, the Cochrane review back in 2014 out of CORE, surgical versus conservative treatment of clavicle fractures, showed to date, all of the randomized trials have found that 15 to 20% of patients develop non-union with non-operative management, surgical fixation with superior fixation, nearly consistent achievement of union, and a low frequency of major complications and satisfaction in patients who had surgical intervention. So that's a study from 2014. Cochrane, who cares? What about some of our newer literature? It's been borne out in the past, and now it's been borne out now. 2014 JSES. This is not coming from the Journal of Indian Physiatry. This is something, these are good literature, good articles out there. Meta-analysis, 7 studies, ORIF versus non-op. ORIF was found to be superior in all randomized studies in the meta-analysis. They had a lower non-union and symptomatic malunion rate. They had better dash and constant scores. They had fewer complications and a better appearance, and patients were much more satisfied. And in their subgroup analysis, they found that the patients that underwent superior plating were the ones that had all of these results due to fixation with superior plating. What about more studies? Another meta-analysis out of JBJS in 2017. 6 randomized control studies, less non-unions, secondary operations for adverse events in ORIF, improved DASH and constant in ORIF. Secondary operations were common in both. So in patients that were treated non-operatively, secondary operations were common. And the most common secondary operation for patients who underwent ORIF was elective hardware removal. So if you eliminate elective hardware removal, secondary operations were much higher in patients that underwent non-surgical treatment of middle third clavicle fractures. So more recent randomized controlled trials favoring ORIF, the Clavicle trial out of Netherlands in 2017, non-union rates at 9 months, 0.8% for ORIF, 11% for non-op. DASH and constant scores were better early and late for ORIF of the clavicle. That shows more data supporting ORIF. So we're seeing a pattern here. Better constant scores early, better DASH scores early, better constant scores late, better DASH scores late. More satisfied patients, higher rates of union, less adverse events with ORIF of this type of fracture. So people will say, if you operate, you can get a complication. There's nothing, if you use steel, you're going to get something wrong. Too many reoperations for ORIF or complications. Well, here's another study out of JSCS. It was a database analysis done by Brian Feely and his group, and also a complementary analysis of what happened in their institution. They found that almost 8,000 patients underwent ORIF from 2007 to 2011. Their results from their institution kind of paralleled what they found from the database review. 12% required hardware removal, only had a 1% non-union rate. Females were 4 times as high to remove the hardware. Excellent outcomes were noted in all patients in regards to DASH and EQ scores. And this guy's a dude. He's not a female. He's not going to want to get his hardware taken out. Another reason to not have another operation. So ORIF does better early and does better late. So Journal of Clinical Orthopedic Trauma, 50 patients followed up for 1 year, ORIF with superior plate versus non-op. ORIF at 1 year, 76% excellent, 16% good, and 8% fair. Look at the non-op, 28% good, 32% fair, 40% poor. None of them were excellent. Need I say more? So is it cost effective? Absolutely. Journal of Orthopedic Trauma, the cost effectiveness was shown acutely, late, and even after 9 years to show that ORIF of the clavicle is very cost effective in treating patients versus non-op. Is it still cost effective? JSCS in 2013, clinical and financial comparison of OR versus non-operative treatment of displaced clavicle fractures, less chronic pain, less weakness, less loss of motion, fewer non-union. This is really important. Missed fewer days of work, 8 days versus 35 days. Cost was $12,000 for operative patients and $18,000 for non-op patients. So you can't tell me that if you operate on somebody, it's going to cost somebody more or going to have more complications. So it's even cost-effective in Betterman workman's comp, which is unbelievable. So JSCS, 76 patients total, 42 non-surgical and 34 surgical. Followed up with time to work and healing at CT scans. Return to work in ORIF was 3 months. Non-op was 3.7. Bone healing was 81% at 3 months via CT on the ORIF and 16% in non-op. The constant scores were higher in ORIF at 6 months and 12 months in work comp patients. Unbelievable. So return to sport. Out of Birmingham, everyone gets back to sport down there 100%, but even in high active athletes that were young, they got back 30 out of 30 at 3 months to playing sport with superior plating. NFL football, landmark article, Patrick Connor out of Ortho Carolina, fixed fractures in NFL football players. They found that 13 displaced fractures were treated, half were treated ORIF, and 7 were treated non-op. They found that 4 out of 7 refractured in the non-op, and 1.5 seasons were missed in patients that underwent non-op treatment of clavicle fractures. Conclusion, displaced fractures of the middle third of the clavicle underwent ORIF in NFL players. He's not an NFL player, but he is a weekend warrior. Malunions are no joke. Oh, they heal, they do great. Many studies have shown difficulty with overhead function, pseudoaneurysm, thoracic outlet syndrome. Plus, if they are dissatisfied with short clavicle syndrome, the surgery is not easy. Sliding osteotomy here, bone grafting, superior plating, big operation, big secondary operation, as opposed to a very simple operation in an acute fracture. So this x-ray in this patient is not a true film. He is laying supine, his arm is splinted. So it looks like it's really non-displaced, but this is a Z fracture. There's 2 butterfly fragments, And if he were to sit up and let gravity assist in this fracture, he will spring like this, he will tent his skin, he'll be very dissatisfied with non-surgical treatment. So my indications for surgery for ORIF or midshaft clavicles are 1.5 centimeter of shortening in the Z fracture, 100% displacement. I'm very wary of the Z fracture. I accept less displacement in collision athletes. Is he a collision athlete by name? No, but he might want to play rugby and football on the weekends. Lengthy time for a union with non-op treatment. Those patients who have severe pain and skin tenting and want to get back to work or activities sooner are the ones that I consider surgical intervention for. Now, don't get me wrong. I don't operate on them all. Here's a 75-year-old pastor of mine. This is his dominant arm, sustained a Z fracture. I recommended non-op. These are his initial films, very similar to the films that we saw from this patient who's 35 and an accountant. At 5 months, he's healed, he's happy, but it did take 5 months, and he is 75 years of age. This guy's 36. So here's a great study from the Journal of Sports Medicine, surgical versus non-surgical treatment for midshaft clavicle fractures. Systematic review and meta-analysis shows that surgical treatment, fewer non-unions, fewer malunions, and accelerated return to work. The results of this meta-analysis favor surgical treatment. However, it should be kept in mind that this is patient-specific and should be taken into account. The final decision for surgical or non-surgical treatment should be based upon shared decision-making between you and the patient, which is what I do every single time. Here's a 31-year-old patient of mine, fell off of a bike, initial ER films, sat him up, he sprung, he was unstable, we fixed him, double plating, he loved it, he's doing great. So in conclusion, for minimally displaced middle third clavicle fractures, non-operative treatment is preferred, but it may take longer than expected to heal, and I elucidate that to the patients. For displaced fractures, this type fracture, ORF is preferable in select patients. Return to activities are variable within 6 to 12 weeks. The most common complication or secondary operation for ORF of the clavicle is hardware removal. I just don't take them out, and if I do, I wait at least a year. ORF is superior to non-op all across the board in regards to DASH, constant scores, cost, patient satisfaction, back to work, so on and so forth. So just fix it, especially this one. And with that, I thank you.
Thanks, Saqib, for the chance to talk again. And it's great to be back here with a good audience. And Jack just quoted a lot of interesting literature, this approach of just fix it. I think we're tending toward this. He talked about the key decision makers as being the patient and the physician, but let me start to introduce the idea that there may be some other variables as part of this decision too. And the scores aren't the same. He quoted some articles, went through them very quickly, but the truth is the scores kind of converge with time, and here's the case. I don't need to go over it again. Let's talk about how we make a decision. I went to a liberal arts college and I took a philosophy course, and part of that philosophy course was how to make decisions. And we talked about a prisoner's dilemma, should I plead guilty or non-guilty? In this case, we're choosing between non-surgical and surgical care, but we make decisions all the time. We may do this consciously or unconsciously, but in our minds we have a decision matrix. Here's somebody buying a car. They're trying to choose between these 4 cars. New Chevrolet, used Mercedes, pre-owned Ford, Uncle Henry's car. And then you have to look at your variables, or what are your options, or what are the decision-making elements, and these need to be looked at independently. In this case, cost, reliability, efficiency, and desirability. And I'm going to apply these things to clavicle, but each column should add up to 1. So if you look at cost, Uncle Henry's car is the cheapest, 0.54, so it gets the highest rating. The other ones are less expensive, and this is just distribution of cost. Reliability, the most reliable, for some reason, the used Mercedes and the pre-owned Ford. And just each column always has to add up to 1, and then you go across the row and add them up, and whichever one's the highest, that's your choice. This is how you should make decisions. Otherwise, you get bogged down in emotional stuff, or you can choose to weight one column very heavily. If you put all your weight in non-union, of course you're going to have surgery. But life isn't that simple, and I think these variables need to be looked at independently. And who's making the decision? Jack suggested that just you and the patient. But maybe there are other people making decisions. Maybe the hospital is. Maybe industry's contributing. Maybe the insurance company has something to say. Maybe society has something to say. And who gets the biggest say? If society is, maybe cost is more important. And if the surgeon is, maybe his pocket is part of the skin in the game here. Maybe he owns a surgery center. Maybe he's got an opening in the schedule. Maybe he likes surgeries. Dr. DeLong suggested a couple talks ago. I think some of the variables in this relate to outcome, and Jack talked a lot about outcome. Time to recovery is important. Variability in terms of predictability, what are our complications, cost, and desirability. And for patients, these are what they want. They want a full recovery, they want it fast, right away, 100% predictable, no complications, no cost, and they want a choice that they really want. And the closer we can get to these, the better. So if we create a matrix for clavicle, it might look something like this: non-surgical and surgical, and these are the things I just talked about: outcome, time, predictability, cost, and desirability. Each column has to add up to 1. Let's look at functional outcome. The clavicle study from the Canadians was already mentioned. It was in 2007, and it started to suggest that outcomes were better in the surgical group. Here were their 52-week scores. Jack didn't show you the graphs, but he showed you some numbers. But in just about every one of these studies, everything converges. Their constant scores were converging, but there was still a little gap. And you got to remember, their non-unions were still living in the non-surgical group, which can be easily fixed. The DASH scores converge, but there's still a little gap at 52 weeks. So in England, they said, we're going to redo this study, but we're going to try and do it better. We're going to put more patients into it, almost 3 times the number of patients. 300 patients randomized, 2017, JBJS. And Jack already quoted this one too, but he didn't show you the data. By 9 months, the groups are equal, constant scores. They're almost equal by 3 months. DASH scores, equal, 9 months, almost equal at 3 months. And their conclusion was that the outcome of a united midshaft clavicle is good regardless of whether the patient was treated operatively or non-operatively. And both are safe, few substantial complications in either group. Let's talk about the complications a little bit. You know, it's easy to harp on non-union, malunion, which are both very correctable through a surgery. There's also this aesthetic issue. Do you want a bump? Do you want a shoulder that droops in a little bit? And I'm not trying to minimize these things. They are complications of this treatment. But there are also significant complications of surgical treatment. You can still have a non-union or a malunion with surgery, infection, which can be horrible, osteomyelitis, multiple surgeries, VACs, rotation flaps. Chest wall numbness is not trivial. The scars are ugly. So you can still have this aesthetic deformity, and others. You can have a perioperative complication, DVT or whatever, add your own anesthesia complication. Cost. This is the bill that the insurance company will see for surgical care, $14,700. Non-surgical care is embarrassing, costs $3,000, because you can give these people a sling and say, see me in 6 months. Cost for non-surgical care should be close to 0. But the cost for surgery is over 3 times the cost of non-surgical care. And this is just the bill the insurance company sees. This does not consider work. And so there are some articles that look at out-of-work issues, but this guy doesn't have to miss any work. He's an accountant. In fact, he'll miss more work having surgery, because he's got to have a day of surgery, couple post-op visits, a day of pain. So he's going to miss more work with surgery. And if you're an epidemiologist looking at public health, you can do the math. You know, we have over 300 million people. The incidence of clavicle fractures is 5.8 per 10,000. If we start operating on all these clavicles, we're going to spend $2.8 billion on fixing clavicles in our country. We're already spending 18% of our GNP on healthcare, and our goal is to decrease this risk while maintaining quality, maintaining good outcomes, keeping in control on complications. And granted, not every clavicle is midshaft, not every is displaced. About 80% are midshaft, 50% of those are displaced. Desirability. Nobody wants surgery. Every patient will tell you that. Isn't there a way to treat this without surgery? So desirability favors non-surgical. Who wants surgery? So if we go back and look at this guy and try and put these things in a grid, because it's easy to get lost in the emotion of non-union and all this kind of stuff, work. But, you know, why are we talking about NFL players? This guy doesn't play in the NFL. Non-surgical and surgical, the outcomes are about the same in about 9 months. If you look at almost all the studies, maybe there's a little bias. In fact, most of them show a little bit early. Functional outcome is better early, but at 9 to 12 months, they're almost all about the same, particularly the later, larger studies. Time investment. The recovery is a little bit quicker with surgery, no doubt. And that's why if you're an NFL player or if you're producing an income of maybe $20,000 to $30,000 per month, you can recoup that $14,000 cost by getting the person back into the workforce quicker. So surgery related to time investment's a little bit quicker. Predictability, about the same amount of complications in either group. Well, you know, pick your complication. The non-surgical group, a little higher, malunion, non-union. The surgical group has all the surgical complications, second surgery, infection, scar, those kind of things. Cost, I just mentioned quickly. Cost certainly favors non-surgical care unless you're in a high-producing income job. NFL football player that Jack mentioned. If you're in workers' comp and you're producing a lot of revenue for that job, then maybe you think about surgical care. Desirability, certainly surgery is the less desirable choice. Nobody wants surgery. And so if you take the emotion out of this and stop harping on a single thing and look across the board, which is your better choice for a mildly displaced clavicle fracture, if you add things up in the top row, by far it exceeds the surgical choice for this injury. So looking at all these things, functional outcome, time investment, predictability, cost and desirability considered together certainly favor non-surgical care, but you can bias this argument looking at a single argument and making this an emotional argument. Or the argument can be perverted if you fail to consider all the players. If you're just looking at what's the best choice for industry, well, then you want to put in as many plates as possible. What's the best choice for the physician who likes to operate, who makes more money operating? You get about 5 times as many RVUs. And if you own your own surgery center, if you own your own therapy facility, if you want to do more x-rays, then yeah, do surgery. Put the physician at the middle of this choice. So the choice of non-surgical care also is not singular. You can also convert it to surgical care. If the person is getting a delayed union, a non-union, a malunion, they easily flip over to surgery. And so I would advocate in this patient with a mildly displaced midshaft clavicle fracture that looking at all the parameters here, all the variabilities, the choice is non-surgical care, which you can easily convert over to surgical care. It avoids the costs and complications of surgery. For this patient who will miss more work with surgery, he'll miss less work without surgery. So he'll miss no work, and you can expect an excellent outcome with both choices. Thanks.
All right, thanks. There's our case again, real quick. 36-year-old male, right-hand dominant. It's the left side. Let's take a vote. ARS. So it's pretty fun when the panelists completely don't believe in what they're arguing for, like the last session. But I think it's also pretty cool when clearly there's some passion behind the decision they're promoting. So we were 50-50, or I would say 49, maybe 51 before. So it looks like non-operative, 60%. So that would be Dr. Fuller is our winner.
Well, it's because I went second. There's a bias to people who speak secondly.
True. Yes, we sort of did that with the whole session here. Any final comments or questions?
He'll have no problem coming over the bridge when he gets his non-union, and I'll take care of him.
What about the fracture of the outer end of the clavicle?
It's not
So
part of
lateral or distal clavicle fracture?
this. This debate was for this specific fracture. Distal third clavicle fractures are a different animal. They have a much higher rate of non-union, but I spoke about this last year. The distal third clavicle fracture, once again, is depending upon displacement, patient factors, age. I tend to treat, most distal third clavicle fractures that I see are in the elderly population. If they do occur in the younger patient population, they're typically displaced with ligamentous instability, which require fixation, but it all depends upon the patient, the personality of the fracture and the patient itself. So for the middle third clavicle fracture, which was this argument, I still would operate on this gentleman, especially with instability.
This one, would you plate it or a screw?
I plate these, superior plate, sometimes double plate.
All right, sounds good. I want to thank the panel again.